of the orthodontic treatment. So after understanding the classification, its impact in the treatment planning, now let's discuss what are the limitations of the orthodontic treatment, because this is the most important thing. You need to know what you can correct it, what you can't correct it. You need orthopedic appliances, and what you can't even correct with the orthodontics and orthopedics, and you need a surgical intervention. And if you need a surgical intervention, your treatment planning is completely different, or rather we say it's completely opposite than orthodontic treatment plan. So you need to identify the surgeon first. You do the surgical planning, and you continue from surgical planning, because there is no way that you start normal orthodontics and then when the problems appear, you say, now you need a surgery. No, the patient should know that it's a surgical case, and we're going to make this malocclusion more worse with braces, and eventually we correct it after surgery. So it's all the psychological patient treatment planning, understanding them from the very start. So what's our boundaries? In orthodontics, in maxilla, we can retract up to 7 millimeters and procline 2 millimeters. With orthopedics, it's just gone up and down. With orthopedics, we can retract 12 millimeters instead of 7 millimeters with headgear, and we can procline up to 5 millimeters instead of 2 millimeters with the help of face mask. So in orthopedics, we use the braces and some headgear or face mask. So headgear and face mask have more potential to produce more effect. So with braces, we can only retract 7 millimeters, but with headgear, we can retract 12 millimeters. So we don't need extractions, which is a very good result if we identify the problem in early childhood. And proclination, like class 3 cases, we can procline it up to 2 millimeters with the braces, but up to 5 millimeters with the help of the face mask. And with the surgery, we have a greater envelope, and same figures increase 15 millimeter retraction and 10 millimeter proclination of the maxilla. In mandible, we can procline 5 millimeters with the help of the braces. And we can procline 10 millimeters with the help of the orthopedic appliances like functional appliance, twin block, or Hertz appliance. And we can procline lower mandible forward up to 12 millimeters with the help of the surgery. Which surgery we do? BSS or mandibular advancement surgery. We can go up to 12 millimeters. So as a rule, we have to see the clinical examination, and we have to see which envelope our patient is fitting, orthodontics, orthopedic, or surgery. For a quick guide, if you get a patient with an overjet of greater than 8 millimeters, or reverse overjet of greater than 4 millimeters, or a transverse discrepancy crossbite of greater than 3 millimeters, you have to prepare yourself and a patient that this is a surgical case. Should not start treating by putting braces. So this is your boundary, which you always remember. You see the overjet, you see the reverse overjet, you see the transverse discrepancy, crossbite. And if any of these figures you feel it's a surgical, do not start with the orthodontic treatment planning. You should do the surgical planning, and you start with the surgical intention.